wait for that to start. Awesome. So, respiratory system today then. Aims and objectives of the session. We're going to talk and go over the functions of the respiratory system, the key parts, the mechanism of respiration and breathing, and then we're going to talk about some key conditions that fall within the respiratory system. It is a recap for you, so there's no new knowledge here for you. So first off then, a nice recap for everyone. We're going to, how many have got? 1, 2, 3. 14. So there's 14 labels on this diagram. I want you to put in a number in of how many you think you'll be able to name. The highest number will get the privilege of naming them. So how many do you think you'll be able to name? Let's put a number in there. Out of 14, how many labels do you think you'll be able to do? Put it in the chat bar. Come on, I've got lots of confidence in you. If not, we have to fall back on Etienne. So the 14 labels, how many do you think you'd be able to name? Well, there you are, so cool. Ed's coming in 10. Ross is Kayla's 10. Etienne's 10. Okay. He'll do more than that. Anyone else? How many do you think? 10-ish. Cool. So let's have a volunteer then. Put your hand up if you want to go through it. Put your hand up and then we'll unmute and we'll go through it nice and slowly. It's a learning environment. It's good to get things wrong. I've got a textbook in front of me, don't worry. I'll get them right. Anyone? Here we are. Cool. Kayla, do you want to come in? If you're unmute.
I can't promise to get them right, but I know
that's all right, don't worry. That's what we're all here for. So if we go down the left-hand side first.
Okay, so it's difficult to know quite where they're pointing. So that could be as simple as nose and mouth.
Yeah, good.
Then could be lung or intercostal space.
Okay.
Yeah, we are lung.
Yeah,
there we go. Sternum and ribs.
Yeah. Sternum.
Ribs.
Yep. Then it goes across, I think, to the top side.
Okay. Nasopharynx, also oropharynx.
Yeah, cool. Nasal passage, awesome.
Oh yeah. Oropharynx.
Yeah.
Yeah. So I'm not sure if that's pointing to the epiglottis or trachea.
Pharynx, epiglottis, yeah, same thing. Good.
And I'm not sure if that's so. There's cartilage rings or
the trachea. I think that is, like you said.
All right. Oh, there are. I can't see where the next one's actually going to, but is that where the trachea splits into the two bronchi?
I think so, yeah. So yeah, the left bronchus. Good.
I'm guessing
I think
that's looking at alveoli or bronchi, depending on where that line ends up. I can't see.
Good.
And then I'm guessing that one might be then the alveoli if that one was the bronchi or bronchioles. So it just can't. Yeah. And I'm not sure what that's pointing to. So are those the intercostal muscles?
So. Good. And then the final one down the bottom.
There is that diaphragm?
Yeah. Awesome. Well done. Very good.
Phew.
Got them all. Well done. Awesome. Thank you, Kayla. So respiratory system. I like to think of it as a bit of a tree. If you turn it upside down, you've got the trunk, which is the trachea. Then it breaks down to the bronchi, bronchioles, which is our kind of branches. And then it goes to those leaves, which is the alveoli. So we talked, or Gayla mentioned the alveoli. So if we break down into those branches and those leaves, so we've got the bronchus, which breaks down to the bronchi, bronchioles, which is the little wind pipes or air pipes. Then it goes to the alveoli, and they are the spongy air sacs that allow us to have that gas exchange. So the alveoli, it is a sponge. Our lungs are sponges. As air goes in, they expand. On the outside of the alveoli, we've got those blood capillaries that allow the gas exchange. And we'll talk about that a little bit later. Cool. Everyone happy with that little recap on the respiratory system? And when we talk about the conditions, it makes sense why we've gone through that and had a little reminder of it. So ventilations versus ventilation versus respiration. I can't even speak today. Respiration. Ventilation versus respiration. What is the difference? Or is there a difference? Put it in the chat bar if you want. Is there a difference? Are they the same thing? Any idea? What's the difference between ventilation and respiration? Cool. So we've got the physical breathing versus the chemical reaction. Awesome. Okay. One done by the patient and one done for the patient, one done by the patient. Cool. Ventilation is breathing, respiration is gas exchange. Good. Airflow versus the process. Awesome. Act as awesome. Cool. Good. So yes, they are different. And this is where we're thinking about, is the breathing rate effective? Are they breathing effectively? Is it below 10, over 30? And then that's why we're thinking ventilation isn't effective, so respiration isn't going to be effective. So we need to assist by pushing some air down into the lungs to allow respiration to happen. So that's why that border is really important. Below 10, over 10, ineffective breathing, we need to recognize it because it's ineffective ventilation. So ventilation is the mechanical movement of air in and out of the body. And then respiration, as you guys said, is the process that results in absorption, transportation, utilization, or the exchanging of respiratory gases between organism and environment. So it's the gas exchange. Awesome. So what is the process of ventilation then? What's the process of breathing? So how do we move that air and how do we ventilate? How do we move the air in? Inspiration's active, expiration's passive. Yeah, good. Okay, we're going to talk about that when we talk about asthma. That's good. Diaphragm moves. Yeah, ribs move. Good. Diaphragm moves down, decreasing the pressure in the chest cavity. Good. Positive and negative pressure created in the lungs. Awesome. Good. So air moves in and out of the lungs because ventilation changes the pressure inside the alveoli, inside those little sacs. This is achieved by changing the volume of the thoracic cavity, that chest cavity. As the volume inside of the cavity increases, the pressure inside decreases. So the chest gets bigger, pressure gets smaller. So the causing of the lungs to expand increases the volume, which decreases the alveoli pressure. And we know air moves into an area of high pressure into an area of low pressure. Once the pressure inside the alveoli drops, below the outside atmosphere, then air will pass into the alveoli. At the end of inspiration, the volume of the cavity decreases, which increases the pressure once it becomes... I'm confused myself now. So yeah, passive decreases when we breathe in, chest gets bigger, decreasing the pressure in our alveoli. Opposite effect, when the chest gets smaller, increases the pressure in our alveoli, which pushes air out. And we always know it goes from positive to kind of lower pressure. How we do that then is using our muscles. So we've got our intercostal muscles and we've got our diaphragm. So it's really important that we understand what they do and why they're so effective. So the diaphragm will flatten, increasing the pressure in our thoracic cavity, and those little intercostal muscles contract, again increasing the area of our lungs. That will decrease the pressure, allowing air to come in. And then again, going out, everything relaxes. Our diaphragm will relax, move up, and our intercostal muscles will kind of relax and push air back out and decrease that pressure within our thoracic cavity. So that is the ventilations. Now we're talking about respiration. We've got an external and internal. So external happens with the gas exchange between the lungs and the pulmonary capillaries. So that's happening within our lungs in those alveoli sacs. Then we've got internal respiration, which is happening around the body. So gas will get into the capillaries, into our blood, and then it will travel around our body and it will exchange between the body cells and tissues that require the oxygen. So that's external and internal. Cool. So we know how we breathe. What do we breathe in then? A little recap again. So we've got a lot of air in our atmosphere, or a lot of gases in our atmosphere. Anyone remember the percentage? How much oxygen do we breathe in? John is gone into 22, 21. 20.4, 21, 21, 21. Again, I think it's the book you read, to be honest. But yeah, this one says 20%. Cool. What about carbon dioxide? How much carbon dioxide do we breathe in? One percent. Cool. It's a tiny amount. Yeah, good. So it's a tiny amount. It's a trace of carbon dioxide. Inert gases, I think is the next one. How much? Again, I think that's going to be 1%. And then the big one, nitrogen. How much nitrogen do we breathe in? Yeah, cool, good. 79%. Awesome. So that's what we breathe in. How about when we breathe out? What is affected then? How much oxygen do we breathe out? So we can see we're breathing carbon dioxide because that's our waste gas. Good. So we're breathing 16% out. Good. How about our carbon dioxide? Oh, cool. Inert gases. The same, and nitrogen. The same. Awesome. Cool. So yeah, we're going to breathe 16 out. We're going to breathe 4% carbon dioxide, and then inert gases and nitrogen doesn't change because we don't absorb them. We don't use them. Awesome. Good. So we don't need a lot of oxygen, to be honest. We only need 4% of what we breathe in to live effectively. And that's why kind of mouth to mouth was always gold standard and worked. But now we're kind of gone to 100% to give them the best chance of survival and reduce that hypoxic response. Cool, good. So what controls the breathing then? And how is it controlled? Yeah, cool, the brain. What does our brain do? How does it control? Cool, CO2, okay. Detects the amount of CO2, good. Sensor in the blood tells us when CO2 increases, measures CO2, good. Excellent, yeah, good. So our little respiratory center is located in the medulla and the pons, which is our kind of brain stem at the bottom of our brain. What else is in control there is the cardiac center, respiratory center. So like you said, the brain is always looking at the carbon dioxide levels and the chemoreceptors within our kind of carotid and aortic body will detect a decrease in the blood pH, and that is down to the carbon dioxide. When they see that, then it's going to increase or decrease the breathing effort and send electrical activity to the diaphragm and those intercostal muscles to breathe a little bit harder or breathe a little bit less. Then we've got the hypoxic drive that we'll talk about a little bit later when we come on to kind of conditions. Cool. So again, that is a little bit more on the anatomy and physiology. So if they've got a head injury, if they've got a base skull fracture, or if they've got a high spinal injury, then we're always worried about some sort of brainstem injury, which would affect the patient's breathing or cardiac center. So going on then, let's do a little bit of assessment. Normal breathing rate, the average. Respiratory rate is always overlooked. It is a really important vital sign. So in adults, if the respiratory rate is over 25, then it does indicate serious illness or a warning your patient may deteriorate quickly. I will hold my hand up and say sometimes I look at their breathing and think, oh, that's fine, do 16. Then I come along and actually count it and it isn't. So it can play tricks on you. So please do a respiratory rate and count it. I'll tell you that. 12 to 20. How about children then? Anyone know what the normal breathing rate for a child would be? Varies on the age. Yeah, good. Cool. Varies on the age, but as long as you understand it's going to be a little bit higher. So 15, 13, and then again for infants. So as long as you know the standard for an adult is 12 to 20, and children will have a higher respiratory rate naturally for them. Cool. So going on to further assessment then, so we need to look at the respiratory rate, don't overlook it. Then we need to look at the normal respiration or normal breathing, ventilations and abnormal breathing. So what are we looking at when we're looking at a patient breathing? So you go out to someone with shortness of breath, what are you looking at when we're assessing their breathing? We've done their respiratory rate. Chest movement, okay, cool. We need to see if the chest is moving. Depth and effort, okay. Rate, depth, noise. If it's laboured, good. Positioning of the patient, yeah, good, really important. See if the chest, neck muscles are working. Good, using those accessory muscles. Any recession, rise and fall of the chest. Okay, good. So, yes, we need to look at the rate and depth of breathing. So if it is shallow breathing or if they're working really hard with their breathing, we need to look at that. Patterns. So is it irregular breathing? Is it tachypneic, dyspneic? Is it fast? Is it slow? Is it painful for them to breathe? If someone's got pain, then that will lead to a reduced rate and depth because they're trying to slow their breathing down because of the pain it's caused. So we need to think about the cause of it as well. Good. Equal, clear, bilateral breathing sounds. So we're not going to be oscillating the chest, but we're going to be looking. So is it equal rise and fall of the chest? If one side of the chest was going up, the other wasn't, what could that be? So chest is unequal, one going up, one going down. Yeah, cool. Collapsed lung, chest injury, chest wall injury, good. No worries, Pauline, absolutely fine. Cool. So that is the kind of equal chest rise and fall. What sort of sounds would we hear then? So if someone's breathing normally, what sounds would we hear? Quiet. Yeah, nothing. Good. Very good. So if we go in and we can't hear their breathing and then normal pallor, then we're thinking normal breathing. If it's not, then when they're struggling, someone said wheezing already. Silent chest isn't good. Good. Air moves in and out smoothly, no problems. Yeah, good. So what about when they're struggling then? So someone's mentioned wheezing, stridor, rattling. So stridor is a high-pitched squeaking, which is an upper airway obstruction. We can hear that a lot in children. Rattling of the chest, snoring. So yeah, if they're snoring, we've got an airway obstruction. Grunting. Grunting, yeah, really bad sign, especially in children. Especially if they've got a head bobbing as well and grunting. It's not a great sign. Gasping, gurgling, good. So if you can hear something, it's not right. We know normal breathing should be silent. We shouldn't be able to hear the air moving in and out really. If we can hear something, then we need to think there's something going on. Good. Rise and fall, both sides of the chest. Yeah, we spoke about that. We spoke about pneumothorax, collapsed lungs, and frail chest. Movement of the abdo. So if someone's breathing normally, we may not see their chest rise and fall. We may just see their stomach going up and down. That is because the diaphragm is doing all the work, which is kind of normal. If not, we're going to think about accessory muscle use. So you may see this in children. If they are sucking their stomach in, then they're using their accessory muscles. So if they've got sucking their stomach in, if they're using their intercostal muscles, and you can note they're sucking in with every breath, then again, they're struggling with their respiratory effort. So normal breathing, it could just be normal with them just using their, you won't see their chest rise and fall. You may just see their stomach moving because their diaphragm's doing all the work. Or if they are struggling, and you've noticed it with other signs, with their wheezing, with stridor, and you've taken the top off and then notice they're using their accessory muscles. They're using the stomach is sucking in, they're using their intercostal muscles, and you can see their neck muscles sucking in as well. Audrey, no worries. Maybe going back, Pauline up. Cool. Additional sounds we spoke about: wheezing, stridor, gurgling, rattling. Awesome. So we can recognize what's normal, what's not. How about what increases our breathing rate? If you go in and someone's breathing really fast, what do you think could be the cause of it? Anxiety, yeah, good. Anxiety, stress. Loss of blood, shock, yeah, good. Panic attack, asthma. Lack of O2, yeah. Hyperventilation, yeah. So what else? A little bit simpler when they're not unwell. Illness, yeah, cool. So what illness would increase? Exercise, yeah, good. So exercise is going to increase it. Gail has mentioned illness. What factor of the illness can increase it? Yes, we've got sepsis and all of that. Bronchitis, chest infection. We're getting there. And fever, temperature change. So if my children are unwell, the first way I can tell they've got temperature is their breathing changes. So they start to breathe out a little bit more forceful. Their mouth open all the time, and that's kind of good signs that they've got a fever and they're trying to cool themselves down. So fever, illness, infection will increase our respiratory as well. Good. How about decreasing then? What would decrease our breathing rate? You go in and someone's got reduced breathing rate. What could be going on with that patient? Opiates, yeah, drug use. Good. So opiates would be our heroin, our fentanyl. Valium now is being laced with fentanyl. So any sort of illegal drugs. Head injury, yeah, good. Any sort of head injury. We know our respiratory center is down in that brain stem. So if we've got a head injury there, then it's going to affect our respiratory center. CVA, yeah, strokes, good. So any condition that can affect the brain may affect that lower part of the respiratory center. So head injuries, strokes, and then those certain drugs, so morphine, our fentanyls, heroin, etc. Cool, very good, well done. So that is the end of the kind of catch up or recap on the respiratory system. We know what kind of controls it. It's the CO2 levels. Our brain's looking at our pH levels all the time. If CO2 increases or decreases, it will affect our pH level. Brain will recognize that and make us breathe a little bit faster or a little bit less to correct that. We know the breakdown of the respiratory system. So air goes in our mouth and nose, down our trachea, breaks down to our bronchus, bronchi, bronchioles, and then finally into those alveoli, those air sacs. When they expand, it allows gas exchange between the alveoli into the capillaries, into our system. What else have we gone through? Yeah, that's about it. So we're going to talk about the relevance of that now when we talk about some conditions and how our respiratory system is affected by respiratory conditions. So COPD then. So COPD, as asthma, it's the same thing. It's an umbrella term that covers a range of respiratory diseases that affects airflow obstruction. So unlike asthma, COPD is not fully reversible and doesn't change remarkably over several months. So asthma is reversible, but COPD isn't. So the breakdown of it, chronic. So chronic means it's a disease that lasts a long time, or it's always present. While symptoms may take several years to develop, and the severity may differ at times, but treatment, it is a chronic condition, and with COPD, it is a kind of terminal condition. But with treatment, it can slow the progress of the disease down, and we can treat signs and symptoms of that patient. So obstructive, all obstructive means it is the ability to move air in and out of the lungs is blocked or obstructed, and normally caused by swelling or the production of extra mucus within those bronchi, bronchioles, which allows air to move in and out. Pulmonary just means the disease is located in the lungs. And then finally, disease just means the lungs have some damage. And even though there isn't a cure, symptoms can be treated to slow the progression of the disease down. So that is the breakdown of COPD. It's a chronic condition. It is kind of terminal. There's no cure to it at the moment. It's all about obstruction of the air moving in and out of the patient's lung, normally through swelling or extra mucus, and it's within the lungs, and it's a disease causing damage to the lungs. Anyone know any causes of COPD? Good. Yeah, smoking. So bronchitis is, bronchitis is a type of COPD, and we're going to talk about that, one of the main types. Cool. So we've got ex-coal miners, dust, heavy industry, air pollution. I suppose those. Cool. So yeah, so harmful pollutions. So if you've had a long-term exposure to dust, fumes, chemicals, ammonia, what else? Carbon monoxide dusts, any toxic fumes, that are kind of the causes. Other things are you can have bird flu, you can have farmers as well will get it from crops they used to use, those chemicals they used to use, farmers' lung. Yeah, rotters come into, and if you guys are in rural communities, then you may come across that. Cool. Then there are some genetic links to COPD as well. So it can be passed down through genetics as well. And what is key is if they've got COPD, then they are prone to more comorbidities and more other medical conditions that fall within. So they normally will have heart disease as well. So people with COPD are normally quite unwell patients. But what is key is all of those causes are down to a worker. They've worked all their life and now they've got COPD and they can't do anything, or they've got reduced mobility to do stuff. So mental health comes in quite a lot with COPD patients as well. And who knows what COVID or long-term COVID will do. This may be the new cause of COPD. So long-term COVID may cause COPD as well. So who knows what the future holds, or it could be another cause to it. Good. So the two types then, one of you's spoken about bronchitis and emphysema are the main ones that you may come across. So if they say, oh, I've got emphysema, then you just need to link to know that they've got COPD, and that does affect your treatment. Or if they say, oh, I've got chronic bronchitis, then link that to COPD. So we'll talk about the two different ones quite quickly. So emphysema, anyone know the difference between emphysema and bronchitis? Yeah, pink puffer, blue bloater. Cool. Anyone know what that means? Anyone know what's happening in that respiratory system to make them pink puffers or blue bloaters? Spaces are enlarged. Yeah, good. Good. Emphysema is, yeah, good. It's the breakdown of the alveoli. Anyone know what bronchitis is? colour and weight, chest walls differences, chronic inflammation. Yeah, good. Okay. Bronchitis, inflammation of the bronchioles. Excellent. You guys have got the knowledge. I'm very impressed. So emphysema then, like Ross says, it is the damage of the alveoli. So the inside wall of the alveoli disappears, making many smaller sacs become larger sacs. With these larger sacs, it doesn't allow gas exchange. So with the breakdown of the alveoli causing these larger sacs reduces the lung's ability to have gas exchange. That will stretch out the lung, make it bigger, make it a little bit more flabby, and again, reducing the ability to have gas exchange. That will cause gas to, or air to remain trapped in those larger spaces, which creates that patient to feel short of breath. So emphysema is the breakdown of the alveoli. Those two images, one is of a kind of CT scan of a very bad pair of lungs, and then you've got that kind of little image there that shows the breakdown of it. So emphysema is a breakdown of alveoli, causing shortness of breath. Chronic bronchitis, like you've said, is the irritation and the inflammation of the bronchial tubes. So that will cause coughing and shortness of breath. It builds up it allows a buildup of mucus within it, which makes the patient cough. So if they've had a cough lasting for at least 3 months, for 2 years, then they can be classed as chronic bronchitis. So what is key with this is little cilia. So cilia is tiny bits of hair that line our bronchial tubes. This hair allows mucus to be pushed up and out. So with chronic bronchitis, they lose it. So it just means they have to cough harder and they cough more, trying to get rid of this extra mucus. So again, some images of a chronic bronchitis. So the little arrows are just pointing to those bronchioles. They're full of phlegm. They've got no cilia to move the phlegm out. So with the buildup of phlegm in those airways, reducing air entry into the lungs, into the alveoli, and again, reducing gas exchange at those alveoli. So emphysema is the breakdown of alveoli. Chronic bronchitis is the inflammation and buildup of mucus within the bronchioles, not allowing gas or air to pass through to the alveoli. So they're the two main types, but again, there's many different types of it, but you just need to be able to recognize it as COPD. So the main symptoms of the both then, so bronchitis, we know it's going to have that productive cough. They're going to have cyanosis. They're going to have tachycardia, tachypnea, so fast heart rate, fast breathing. Dyspnea is difficulty in breathing. They're going to feel short of breath because of those airways being blocked full of mucus. They can't get air in. They may use accessory muscles because, again, they use more effort to get air in, and then it will lead to other conditions, other core mobility, so high blood pressure, heart failure, etc. Emphysema, then they're usually a little bit thinner. So this is our pink puffers. Cyanosis, tachycardia, tachypnea, dyspnea, use of accessory muscles, all of the same thing. But they use accessory muscles and exhalation because air is getting trapped in that bigger alveoli sacs. So the alveoli break down, causing air to get trapped in. They're trying to get rid of it, so they use more effort to get air out because it's being trapped in their lungs. So they're the two main differences. Pink puffer is emphysema. Blue bloater is the bronchitis, but I don't like those terms. They're not very nice. But as long as you know one's got a productive cough, the other one hasn't. and that's rationale behind. So what is important when we talk about COPD and treat COPD is the hypoxic drive. So the hypoxic drive, we know now CO2 levels in the blood stimulates our brain to cause us to breathe a little bit faster. It looks at the pH levels. With a COPD patient, they have higher CO2 levels in their blood. With higher CO2 levels, causes the chemoreceptors, those little soldiers in our aorta looking at the CO2 levels, to get desensitized to it. So with higher CO2 levels, our brain can't kind of look at it anymore. They can't recognize it anymore. So all that means is, because they can't see CO2 with our COPD patient, our brain now looks at the O2 levels to regulate our breathing rate. So hypoxia becomes a stimulant for the patient to breathe. So higher the O2 level removes the stimulant for the patient to breathe. And that's why we've got the different O2 levels for a COPD patient and for a normal healthy patient, because we're now looking at the O2. If we give them too much O2, then it's going to reduce their stimulant to breathe. Cool. So management then, we're going to do a primary survey. We're going to do our secondary survey. We're going to do some observations. We're going to do our sample. We're going to treat them. We're going to give them some oxygen therapy if required. Position's really important. We spoke about position when we're recognizing when someone's struggling. We're not going to lie them down. We're going to sit them up. If they're in bed, let's put a few extra pillows behind them. If they're standing, then you may find them in a tripod position, trying to open their air chest up cavity as much as possible. Then you're going to hand over. Let's not overcomplicate it. You treat what you can see. We know we've got backup coming, so we're just going to treat the patient, treat what you can see, and make them better when we can. So from this last year's CPD, the clinical updates in the oxygen guidelines. So we know for COPD patients, they have low dose supplementary oxygen with a target range of 88 to 92%. So what's new is we now treat the patient as if they've got it. So if you've got a patient that fits the criteria, over the age of 50, they're a long-term smoker with a history of breathlessness and exertion with no other clinical cause, now these patients should be treated as if they've got COPD. So it's really important that we get a history from your patient. If they fall within that category, even if they're not diagnosed, we're going to treat them as if they've got COPD and they fall within that 88 to 92% target range. So that's the key for COPD patients. Don't give them too much oxygen. Give them too much, we're going to reduce their stimulant to breathe. Cool. So that's COPD. Everyone happy? Talking too much. 10 minutes left. So asthma then. What is asthma? Let's have some ideas. We talked about chronic COPD. What is asthma? So fully reversible air obstruction, okay. Inflammation of bronchi, umbrella term, lots of conditions under it again. Yeah, good. Unable to exhale air. Okay, good. Bronchoconstriction. Excellent. So asthma is a condition that is intermittent, it's reversible of the airway obstruction. So COPD is chronic all the time, may get better now and again, but with asthma, it is intermittent and reversible. Cool. So what's going on then? So asthma is caused by chronic inflammation of the bronchi, making them narrow. The muscle around the bronchi becomes irritated and contracts. Caused by it can cause sudden worsening of symptoms. The inflammation can also produce mucus and produce excessive mucus that will block those airway passages. And you can see that in that little image down the bottom. You've got a normal airway, then it starts to constrict because it's irritated, then mucus is built up and it gets even smaller. So the key 3 factors that we're thinking about when we're talking about asthma is increase production of bronchi mucus, swelling of those mucus cells causing the bronchi and bronchioles to inflame and constrict, and then spasming and constriction of the bronchi muscles. So with asthma, because I know Etienne mentioned something there, because inspiration is an active process involving muscles in our diaphragm and those intercostal muscles, we can use our accessory muscles as well to force air in. Air can pass through and overcome those obstructions when we're breathing in. When we're breathing out, exhaling, that occurs through muscle relaxation. And with asthma, this is severely delayed. So the narrowing of the airway in asthma generates the kind of the wheezing, the stridor and that condition. So that's why it's harder for the patient to breathe out, because it's an active movement with muscles to contract to get air in. But coming out, it's all about relaxation, and our airways can't relax because they are swollen, they're full of mucus, so it's very delayed. So they normally can't get air out, and that's why they have expiratory wheeze or stridor. So asthma can be treated either through tablets or inhaled medication. So broadly, inhalers there's 2 main forms. You've got the preventer, which is the anti-inflammatory medication, normally includes steroids. So over a long time, that reduces the inflammatory action caused by asthma. Then we've got the reliever, which is normally the blue salbutamol inhaler. And that works by rapidly relaxing the smooth muscle and the spasming of the airways. The other tablet would be some sort of course of steroids, prednisolone or something that, again, to reduce the spasming or the inflammation of the airway. So they're the 2 kind of main types. Really important that they've got that reliever and the blue salbutamol inhaler should be their first course of action with it. And they normally have their own action plan. If they've got a spacer device, they should be using it. If you're having an asthma attack, then the ability to use an inhaler does diminish because you've got anxiety, you're trying to breathe a little bit harder, and you're thinking about a lot of things, so it's really hard to take an inhaler properly. So if they've got a spacer device, they should be using it. Please encourage them to use it. And normally they've got an action plan. They'll put 10 puffs into the puffer, then they'll breathe in and out through it to get the full dose of the salbutamol inhaler. So triggers then. What sort of triggers can cause asthma? I'm going to run over a little bit. I'm going to go through it. So you probably know it. Yeah, stress, pollen, dust, exercise, infection can bring it on. Cigarette smoke, change of temperature. So if they go out into a cold environment, they may get it. Other history behind that patient, you would normally find Typically, they'll tell you they've had increased shortness of breath and wheezing over the last 6 to 48 hours. And in that time, they've increased their use of the inhaler. So if you've got a history of their trigger and they're using the inhaler a little bit more, they're feeling a little bit short of breath in the last 48 hours, then we need to be considering asthma. Signs and symptoms we know, we've talked about, and you can recognize it. So it's really important to recognize the severity of it. So if they've got a SpO2 of over 92, their respiratory rate is below 25, heart rate below 110, then we're going to class it as moderate asthma. If they've got a SpO2 again of over 92, but now their breathing rate and heart rate are above 25 and 110, then we're going to class it as severe. Life-threatening is SpO2 below 92, and then this is where if they've got a silent chest, they've got no air movement, their airways are constricted so they can't get any air in or out, really bad sign. Poor respiratory effort, if they tell you they're exhausted, it is a danger sign, it's a red flag for you. If they're getting confused, if they're cyanotic, hypertension, arrhythmias, you probably wouldn't see, but if they're saying they've got chest pain, then it is life-threatening. And if they've said any one of those symptoms, that will qualify them to go into the higher severity of it. So if you've got a patient with a SpO2 of 91, they go straight into a life-threatening category. So if you recognised it, please update control so they can upgrade your response to you. Management, same as before, just treat what you can see. Give them oxygen if required. Hyperventilation we'll talk about because it can get mixed up with asthma. So hyperventilation is caused by overbreathing. Overbreathing causes a decrease in the carbon dioxide levels in our circulation. And again, asthma and hyperventilation can be related. So how we'd recognize it is increase respiratory rate and depth. They will or potentially feel short of breath. They'll feel cold. The hands may cramp up. Fingers may cramp up and go numb. They'll feel dizzy. They may faint. And they may have some sort of palpitations or chest pains. But their SpO2 levels will remain normal because it's a buildup of CO2. They shouldn't get hypoxic through it traditionally. Management of it is remove them from the trigger, remove them from the environment. They have to go into a calm environment. Then you need to be firm, kind and reassuring to them. So it's all about breathing techniques with hyperventilating patients. Still assess them because we need to make sure it is hyperventilating and they're not got asthma. So if they're just hyperventilating, then calm environment, firm but kind reassurance to them. Breathing techniques, give them something to drink, give them some water. If they're drinking, they're not breathing. And that's what we need to do, just slow their breathing down. We do not use paper bags anymore. Get them to read a book out loud. Yeah, good. Anything to take their mind off their breathing. Get them to fill your paperwork out. That will slow them down and make them think about something else. Cool. Last one. I know we're going to go over, but we'll go through it. So pneumonia then. Again, this is something that you will come across and one of the main respiratory conditions. So pneumonia is an infection of the terminal bronchioles and the alveoli. So turn that tree upside down. We're talking about the little trunk, the little branches and the leaves is affected in pneumonia. So this is a inflammation process, typically due to a bacteria or a viral infection. Normally, this will be killed off by our immune system, but for some reason it's got down into our lungs and it is multiplying, which has caused and resulted in this infection in the lower kind of terminal part of our respiratory system, the bronchioles and the alveoli. This leads up to a buildup of fluid and blood cells in the alveoli, which is known as consolidation. So if you hear that on the X-ray, they've said, "Oh, you've got a bit." That is down to or classed as pneumonia. Anyone know any patients that would be a high risk factor for pneumonia? Any patients that would give them high risk? Immobile, yeah, good. Elderly, COVID, COPD, yeah, good. So any chronic heart or lung disease, COPD, yeah, chronic bronchitis is a key one for that. Previous TB, bronchitis, surgery, yeah, immunosuppressive, good. Cigarette smoke, and the last two you've missed out is any excess alcohol or drug abuse. So if you do go to someone who is alcohol dependent or a drug user and they have got shortness of breath, then they are at higher risk of pneumonia through it. So please do assess them properly to see what is going on and get a good history take from them. Cool, good, well done. So signs and symptoms then. They may have a fever with or without rigor. So they get those shakes at night. Cough, often productive with green, blood-stained, rusty kind of sputum. They will have chest pain, muscular chest pain. They'll have joint pains, just like when you've got the flu, you can feel rough with it. And then on your assessment, they're going to be tachycardic, tachypneic, and pyrexic. So fast heart rate, fast breathing, and have a temperature. All signs of an infection. Treatment. As you guessed, we're going to do our primary survey. We're going to do our secondary survey, get that history take from them. We're going to treat them. Position, really important. Normally, if they're elderly and well, they're in bed, blanket on, and lying flat. So we're going to sit them up. We're going to open the window, take their big old duvet off, give them a blanket, and cool them off, and give them O2 if required. And then we can hand over to the ambulance crew as well. Please don't forget your sepsis as well. If they have got a chest infection or pneumonia, and they've got those risk factors behind pneumonia, then they've got a higher risk of sepsis as well. So we need to be considering sepsis with your assessment. If you have got feasibility, then you will be doing your news score on these patients. And we're going to be rolling out observations to everyone soon, so you will all learn about news scoring on your CPD this year. Cool. Last bit was a little bit rushed, I apologize, but has anyone got any questions about anything we've covered today in the last hour? Was it beneficial? Was it too fast? Everyone got home. Everyone got out into the sun. So, smoke. So, smoker with asthma over 50, they wouldn't hit the criteria because they've got a clinical reason for the breathlessness. Unless you've got your history of they're breathless all the time and it's not linked to asthma. If they're only breathless when they have asthma kind of flare up, then they wouldn't fall within it. But if their history is, oh, I'm a smoker, I'm over 50, I'm breathless all the time, but I've had asthma all my life, but the history is breathless all the time on exertion, then they would fall in with it. If they said, I'm a smoker over 50, I get breathless when I have my asthma episodes, when I'm stressed and I have my inhaler and then it goes away, then they wouldn't fall within it. But if in doubt, just treat them as if they've got COPD. You're not going to do anything wrong. There's going to be backup coming up to you. And you've got the clinical desk there for you. So if you're in that situation, Gayla, phone the clinical desk up, speak to a clinician. They'll be able to support your clinical decision making. Cool, so good recap. Awesome, good. So thank you all. I'm going to start